to today's episode on pelvic health. Today we have Amadea Kezar, who is a pelvic health physiotherapist and owner of M.SC Physiotherapy, a pelvic health clinic in Montreal. She's been treating pelvic floor dysfunction and related conditions for 11 years, and her clinic treats a wide range of issues, including urinary, bowel, and pelvic pain conditions. Thank you so much, Amadea, for being here with me today.
My pleasure.
So
Thank
I thought we can. Oh, sorry, I got you off there. I thought we can start off maybe with a little introduction regarding pelvic health, or maybe even the pelvic floor, what exactly it is.
Yeah. So the pelvic floor are all of the muscles, connective tissue, and nerves inside and at the base of the pelvis. So I can actually show you. So I have a model here. So this would be like cis female anatomy. And so when somebody is on my table, say they're on their back, this is the view that I have. And so if you're standing up, these are all of the muscles under you, and we all have them, okay? And so we have muscles that attach from the pubic bone in the front. All of the dark guys are the superficial layer. Then the light pink is the deep layer, and they swing all the way back to the tailbone. Mm-hmm. And so these guys are really important for urinary control. So keeping urine in, letting it out when we need to or want to. Bowel control, again, keeping in, letting out on demand, and sexual function. And so then if we start to see issues in this area, say so much more tension than we're most supposed to have, or the reflexes are not at the right time, or it could be a weakness issue. Sometimes it's a lack of coordination. Well, then we see issues arise with urinary control, bowel control, and pain conditions.
All right, that's cool. Thank you for showing us. So I know a lot of these conditions are fairly common, and I was wondering if you could talk to us about some of the common conditions or common things you often see in your clinic.
Yeah. So overall, I would say we're seeing urinary issues. So that could be urine leakage. It could also be frequent and urgent urination. It's about 40% of cis women that have urine leakage. So massive numbers. At menopause, that jumps to something like 75%. Wow. It's huge, just so common. So what I say all the time is it's too common to be taboo. Yeah, absolutely. Men as well can have urinary issues. A lot of post-prostatectomy patients, so if they've had their prostate removed, a lot of men leak and they have erectile dysfunction as well. So that's one category. So urinary. Bowel issues would be, say, anal urgency and leakage, or chronic constipation, and we treat that. Could be anal pain as well. And then from the pain perspective, we're seeing spontaneous genital pain, abdominal pain, and pelvic pain, and then as well pain with sex, or like with vaginal penetration, or pain with erection and ejaculation. So those are kind of like the three broad categories. And then of course, I think that pelvic health physios are well known for pregnancy and postpartum care. And so anybody that's having a baby or is postnatal could have any of those issues as well.
So just out of curiosity, I know a lot of the examples you gave, particularly we put emphasis on, the older spectrum of the population. Can you speak a little bit about like how common this is in the younger population? Because I think that's often something that people overlook. So just a little curious about that.
Absolutely. So when I was talking about the urinary issues, that's 40% like kind of across the board, like postnatal on. So that could be, a 20-something-year-old, 30-something-year-old that's had a child, and then on from there. For pain, so let's say pain with vaginal penetration, so pain with sex, what we call dyspareunia, that's actually 1 in 5 women.
Wow.
And the research that was conducted in that area, that is true from women that are 18 years old through menopause. So huge, massive numbers. If we're talking about pelvic pain, it's about 25% of
crazy.
massive numbers. And it's just so common. Like we all probably know somebody that is managing or dealing with some sort of issue. The problem is we're not talking about it.
Yeah. So that brings me kind of to my next point. A lot of these things, I feel like people often get embarrassed or think it's not appropriate to bring up, or they don't know they have to bring it up. Can you talk a little bit about like maybe the stigma or taboo that you often see people present? Like, why are they hesitant to talk about it? What is with our culture that we don't want to normalize talking about it?
Well, I think the genitals in general are still taboo, even in
Yeah.
2021, and people don't like to talk about this area. I think some of it is learned. I think we learn that it's meant to be a hidden area. It's meant to be highly protected and
Yeah.
guarded, and we whisper about it. We might talk about it with our physician. So a lot of people aren't even disclosing their issues with their doctors. And I think that is passed down generationally.
For sure.
I really do. And it's really unfortunate. And I think some of the education surrounding the genitalia and sexual health also perpetuates some stigma and fear. And so often I talk about, so I treat a lot of women having pain with intercourse. And I say, oftentimes I think that we're setting people up in some cases to experience pain just from poor education. So the number of people that I have in the office that believe that their hymen is completely covered until there's some sort of penetration there.
Yeah.
I think that's a huge fail.
Yeah.
Failed our young women with poor education, because that's not the case. The hymen has a space and it's meant to be stretched. And so I think it's those sort of misconceptions and just poor education down the line that sets people up for a lot of fear factor. And then the fear factor also contributes to not speaking up because they're scared. And the other thing is, I think the less one person talks about something, well, it doesn't really give a space for other people to come forward, right? So I'm silent about my issues, and so you're silent about yours, and we're sitting next to each other.
Absolutely.
And so it just kind of perpetuates itself, and it's really a shame. It really is a shame. And so, here at Ask, one of my lines when I'm treating patients often is, okay, now that you are now an ambassador, and he starts talking about the statistics, like someone is dealing with something, like you need to be talking about what's going on with you. So
absolutely. It's just mind-blowing to think, we're often so fascinated by stats, but this stat being so big is not driving enough change to the point of like us talking about it openly is kind of like surprising. But again, I think it's the fact that it's related to the genitals, and anything in the genitalia area is like forbidden territory.
Absolutely. It's forbidden. And also I think that we believe there's just this misconception that a lot of dysfunctions are normal. Like it's normal to have pain with sex your first time. It's normal to leak after you have a baby. It's women have issues or like, so I think that's also the problem, the fact that we've normalized dysfunction. And so that we need to change that narrative as well.
Yeah. All right. So just to kind of summarizing things things we can do, because I'm just always curious in terms of like, what can I take away from this, aside from, of course, I think the biggest thing is going to be open discussions, raising awareness, and like educational changes. And that unfortunately is like way beyond my scope of reach. But at some point, I do think, hopefully, that they start integrating everything that we're having in these conversations to educational programs, because I think it can start there as well.
100%, absolutely. But I think it's podcasts like this that are actually paving the way for change. You're creating the discussion, you are breaking the taboo. So I think social media has had a powerful effect on moving things forward. There's still a lot of work to do, but I think that that's a good place, and that's where the young people are. So let's get them where
Absolutely.
they are, really,
Absolutely. All right. So in terms of transition point, I was thinking, a lot of these conditions, how does your role as a physiotherapist or someone who specialized in pelvic pain as a physiotherapist, like what do you do specifically to like help these certain conditions? I know probably your scope of practice is too big and too large to talk about in this short podcast, but like some of the things that you can offer that people may be like, oh, wait, that's cool, I could benefit from that.
Yeah. Okay. Well, I mean, we can summarize that, I think, fairly easily. It depends on what the issue is. So is the issue a weakness problem? Are people having a hard time accessing and contracting the pelvic floor muscles, quote, which is a Kegel, right? A contraction of the pelvic floor is a Kegel. Are they having trouble doing that, or is it not strong enough to say support urinary control, bowel control? Well, then we'll work on very specific isolation exercises. So the hardest part is finding these muscles because we're not well connected to them. We don't see them. So we have to help somebody find them. And then can they move them through the range with some strength? And then it's about coordinating them with the rest of the core, because your pelvic floor is actually a piece of your core. So that would be sort of one aspect. And then if that person wanted to get back to sort of impact activities or activities that require more effort, well, then we would get into more functional exercises, like how do we progress somebody to be able to run and jump and play with their kids and do their Zumba class or lift weights or whatever. So then we would tailor the more active portion of the therapy towards that. For pain, it's a bit different. So if somebody's coming in with pain, I think the first start, or how I treat it, is first to educate them about what pain is. So pain is actually very protective, and it's a product of your brain. Your brain decides very quickly to create pain if it feels that you need to be aware of something, basically, is what pain is. And so by really educating somebody about what pain is and why they might be experiencing it as a function of that understanding, you can reduce a lot of fear. And when we reduce a lot of fear of discomfort, well, people start to move more and they can tolerate more stretch and pressure and movement, et cetera. So that's the first piece, is to understand what it is. And then we're working on oftentimes releasing the pelvic floor. So what we're seeing is that the pelvic floor muscles are overactive. They're too tight. So either they're held statically tight, so the anus is tight, the vagina is tight, or they're spasming. So either on vaginal penetration, they're spasming, or maybe sometimes when people pass a bowel movement, it causes stretch and then it causes them to contract. So there are a number of reasons why, but it's tension. And then we look outside of the pelvis as well. So is the skin moving well, the connective tissue? So all of the connective tissues between the skin and the muscle, they need to glide, and we can develop connective tissue restrictions. And when you have that, that can cause pain of its own and reduce mobility, but also can irritate the nerves that are passing through that area. So we're working on muscle tension, connective tissue release. We might be working on flexibility of the muscles around the pelvic floor, around the pelvis, around the trunk, the abdomen. Relaxation is a big piece of it. So learning how to breathe deeply. Again, when we're in pain, we breathe in our neck. Can we have a diaphragmatic breath and abdominal breath? Can we actively let go? And can we, in the moment, we teach strategies. So if you're experiencing pain, how do we not respond with more tension? How do we learn to turn that down through softness? And so these are all strategies and concrete exercises that we teach, and we build a toolbox for our patients so that they have the tools to pull out when they need to. Yeah. And I would say, for patients that are coming, having pain with vaginal penetration, because that's a huge population that we see here. I said I was going to have a little show and tell. So what we'll use for these patients, and also I would like to say we also treat the trans population. And so post-surgically, we need to do similar exercises for the neovagina if they've had a gender confirmation surgery as well. And so we'll use a dilator. And so this is an example of a dilator or an accommodator. And so this is the big size. So we would start with something smaller. But the idea here is that somebody can learn how to relax the muscles to allow something to be inserted with comfort. And then we can use the dilator, it's always in comfort, pain-free, to stretch and create flexibility and capacity in those muscles so that they can start to accommodate something of a larger and larger size. And we can do this intravaginally, and we can do it intraanally as well. Sometimes we need to work on the flexibility of the muscles around the anus for a number of reasons. It could be pain with bowel movement, it could be pain with anal sex, it could be any number of reasons. And so we just progress the size to whatever the patient wants or needs. And so that's dilator therapy in a nutshell.
It's actually really cool. I think this is not the only, but the interconnection between kind of like the emotional mental health of it and the pain is huge. And I think not that it's overlooked, but people don't really take the time to think about how interconnected it is. And like that you work on both at the same time when you're addressing this. And I find that's really cool.
It's necessary. You can't disconnect the two. And, when we start talking about pain and the brain, what a lot of my patients will say is, oh, I know it's in my head. Like, it's not in your head, it's in your nervous system. That's the connection between the emotion and the psychological aspect and the muscles and the joints and your movement and your reflexes, right? It's the nervous system. It's very concrete. The retraining that we're doing, we're just learning new patterns, and it takes repetition and it takes practice and it takes calm without those strategies to stick. And so that's sort of the idea behind that. But mental health is massive, and we work very closely with psychology, sexology, psychiatry in some cases for more severe cases.
Really cool. Really cool. In terms of, okay, so we have all these services, and my next question comes down to, I know since it's not really like the topic of conversation in many like our health related domains and like politically centered people who make political decisions regarding health, let's just say that. So how accessible is this care? Because I know sometimes the care that's necessary and should be easily accessible isn't always. So how accessible would you say this is in terms of like, let's say Montreal, for instance? Can we easily find someone who's specialized in pelvic pain physio?
Yeah, I would say in Montreal, I think we're very fortunate. It's very accessible. It's not as accessible as, say, orthopedic physio, right? The guys that are treating the backs and elbows and such. But I would say it's growing rapidly. I'm pretty confident that there's somebody in most quartiers or boroughs in Montreal. I'm confident about that. And access, I think the barrier to access is really knowing that we exist. So the number of patients that come in and say, I had no idea. I was like, I wish I could have $1 for everyone that said that. So I think the barrier there is that. I think there's a barrier at primary care, like family medicine physicians and gynecology. Like doctors are still kind of the gatekeepers. And I feel, and I work with some fantastic doctors, like we need them, they're amazing. But there is still a barrier where it's not reflex yet. Like it's reflex to send somebody for an ankle sprain, but it's not reflex yet to send somebody for urine leakage or pelvic pain or pain with sex. It's not reflex. And so I think that becomes a barrier. In terms of sort of, you were talking about access. It's direct access. You don't need a prescription to come. So it's like any other physio. You can just call in and make an appointment and we'll see you. And then if we need to contact your physician, we will. So that's good news. Maybe what might be a bit of a challenge is it is more expensive than orthopedic physio in some cases, but the sessions are typically an hour a piece versus say a half an hour or sometimes less in orthopedics. So sometimes that can be a barrier. I would say the physios that I know that work in this domain, they work really hard to be as accommodating for patients as possible, taking into account finances. So making every session really count, making sure patients are really autonomous in their work because you don't want to have that barrier. And then there are physios out there that have, sliding scales or some sort of bursary program that can help offset the costs.
Cool. Really reassuring to hear that it's available, because I think that's also something else people aren't aware of. Like they may know they have the problem, but they may not know where to go. So thank you for that. And I think the last thing, you kind of already addressed it, but in terms of like advice, let's say for people going into healthcare or people in healthcare or like primary care physicians, are we doing enough to address pelvic pain or like pelvic issues, pelvic related issues in office or like in the hospital? And if not, like what advice do you have for us, at least as like students going into the healthcare? What should we keep in mind? Like at what point should we should we consider involving you guys, or even like talking to you guys about it? Like, any advice, any words of like wisdom?
Yeah, I think having a proper medical exam is important. I'll never say no to that. You should have things ruled out. I would say if your results, because we see this often, I'll explain what happens in clinic in real life, but if your results are coming back negative, so you're having pain, say, pelvic pain, abdominal pain, pelvic pain, genital pain, and they're going to typically test you, they're going to do a urinary culture, maybe a vaginal culture. They might send you for bladder ultrasound or an endovaginal ultrasound, abdominal ultrasound, those types of things. If your scans and your cultures are coming back negative, find one of us. Find a physio to also assess the functional aspect of your issue. So there's the medical aspect, which is tissue healing. And then there's the functional, like what is too tight that needs to be relaxed, what is not fully under your control that should be, what is too weak that needs to be strengthened. It's the functional aspect. And so it's that aspect that we don't often consider, but it really should be a part of the initial screening, to rule these things out as well, with the cultures and the MRIs and the CTs and all of these things. So that is a really strong indication that there might be something else going on. And so what we see in clinic, and it's very sad, particularly with pain, we will see people with pelvic pain who have had the negative cultures and scans and testing and still have been prescribed antibiotics repetitively, and knowing full well that the cultures are negative. And by going through this repetitive process, they're not getting to physio for 5, 6, 7, 10 years after their initial symptoms arose. And so I think that is a big telltale. And then for anybody that's pregnant or delivering or has had a child, I think it's absolutely necessary, absolutely necessary to assess how those muscles or how your abdomen is doing. It has been stretched. And the stat is actually during a vaginal delivery, the pelvic floor stretches up to 3.5 times its length.
Wow.
Massive. And so if that were to happen to your leg muscle, there'd be no question you would be sent to physio. But we just kind of assume that things are going to heal. And that doesn't really make sense. Yeah. So those would be some big telltales for me.
All right, that's cool. Thank you for that. I'm going to keep that in mind. And I hope people listening keep that in mind. And I think there was a lot of insight that you gave us in terms of like what to keep an eye out for, or like just think about how we feel. And is there anything that like hearing you talk was like, oh, maybe I should bring it up. So thank you for that. And thank you for helping me raise awareness for this regarding chronic pelvic pain.
Absolutely. It's a passion of mine. It's a great pleasure to be here. Thank you for raising awareness and for inviting me. It's an absolute pleasure.
No problem.